submit, everyone.
Okay. And I'm going to head out.
Okay, thank you, Desmond.
No problem.
All right, good afternoon, everybody, and welcome to this month's time lecture. For those of you I haven't met, my name is David Salzman. I'm one of the faculty in the Department of Medical Education and Emergency Medicine. And it's my great pleasure today to lead us in this discussion, to introduce our speaker, and then provide any additional information. Please be aware that this lecture is being recorded. Faculty can receive CME credit. In order to get that CME credit, please make sure that you fill out the post-event survey in the announcement or on the Time website. If you want to get that CME credit, make sure you include your name so they can get to you. Today, we welcome Dr. Yue-Yung Hu. And the title of today's lecture is From First to Second, a National Cluster Randomized Control Trial to Improve the Learning Environment and Resident Well-Being. Dr. Hu is a pediatric surgeon at Lurie Children's Hospital. She is a health services researcher and is a faculty member of the Surgical Outcomes Quality Improvement Center at Feinberg. She studies surgical outcomes, quality, safety, and education. And so without any further ado, it is my great pleasure to be able to introduce this month's Time speaker, Dr. Hu. Welcome, and we look forward to hearing your presentation. As you're getting your slides set up and ready, if there are questions that come up, feel free to put those into the chat. I will help to collate, organize, bring those to the attention of Dr. Hu, or we can touch on them at the end as well. All right, Dr. Hu.
All right, thanks for the spotlight. I love talking to other medical educators and also talking about our work. So it feels very self-indulgent. So we're talking about the second trial. And just to start, I'll go over some of the salient points of the first trial and how that led us to the second. This work was all done, full disclosure, by Carl Bimore and the team at so quick before I even started here. But I can summarize the points that are relevant. So the first trial stands for Flexibility and Duty Hour Restrictions for Surgical Trainees, a mouthful, as is second. There were 117 surgical residency programs enrolled, and they were randomized to either standard policy or flexible policy. For both arms, these three ACGME duty hour restrictions stayed in place. So both arms had an 80-hour per week work limit. They required the 1 day off in 7 and call no more frequently than every third night. The flexible arm programs could flex any of these policies that you see. And since it was a pragmatic trial, it was up to them what they wanted to flex. There were two main outcomes for the first trial, which collected data from 2014 to 2015. The first was patient outcomes, and that used National Surgical Quality Improvement Program data. And the second was resident outcomes, and that was measured using a survey that was given out after the annual American Board of Surgery in Training examination, which is taken by all residents training in ACGME accredited general surgery programs. So the primary outcome demonstrated that there was that flexible policy was non-inferior to standard policy in terms of death and serious morbidity. There was also non-inferiority demonstrated for all the other NSQIP outcomes. In terms of the resident outcomes, flexible hours were also non-inferior to standard duty hours, specifically in terms of their perceptions of the quality of their education as well as their overall well-being. The well-being one is particularly interesting in the context of these first three charts you see here. So they did all perceive a negative effect of flexible hours on their time for health, rest, and family and friends. But after intern year, their overall well-being was still better with flexible policies. In fact, when they asked flexible policy residents if they could go back and pick a residency with either flexible or standard duty hours, most preferred flexible policy. And so did senior residents in the standard policy arm. And these findings contrast sharply with the findings of the iCompare trial, which was essentially the first trial conducted in internal medicine residents using Medicare instead of NSQIP data. So So medicine residents randomized to flexible hours had worse overall well-being and worse perceptions of the quality of their education. The ACGME then changed the common program requirements to allow for flexibility in duty hours. And you can see the reaction was quite different for the different specialties. Here, a medical student is commenting that surgical residents are oddly excited about the policy change. And this is why flexible hour residents were less likely to have to leave during an operation, miss an operation, or hand off an active care issue. So they were less likely to miss out on the part of residency that's really meaningful to them. The 4 years of follow-up data after the first trial demonstrated well-being declining, however, in both arms, which leads me to believe that it's not, as most people believe, about the hours. So what is it about then? So these are quotes that we gather through our qualitative data that I'll talk about a little bit later. So despite a lot of surgeons thinking wellness means you don't want to work that hard and you don't really want to be training, wellness is not really about the hours. So what is burnout about then? So burnout is a topic that is pretty much ubiquitous. It's in every major journal. There's tons of research which shows that it has profound consequences for patients, providers, and the healthcare system. Addressing burnout has become a priority for the National Academy of Medicine and the AHRQ. The ACGME has common program requirements that include a provision about resident well-being, and they specify key issues for programs to consider, for example, time with patients, autonomy, workplace safety, but they don't really provide guidance as to how to do these things, which may be trickier than it sounds. Take this provision, for example. Programs should provide access to appropriate tools for self-screening. That may sound straightforward, but there are many instruments out there for measuring well-being. The most commonly used is the Maslach Burnout Inventory. However, it's proprietary, so programs would have to pay for it. And expenses like that may not be trivial, may limit what programs could do on the back end when they have that data. Second, multiple versions of the MBI exist. So how do programs know which one to choose? Third, there's no standard method for scoring it. A recent systematic review published in JAMA cites 142 unique definitions published in the literature. So even if a program is particularly motivated, they figure out what instrument to use, how to pay for it, administers it, convinces the residents to respond despite all the stigma about mental health, and chooses to analyze it. How do they know if that rate is bad or good? So for illustration, the MBI has 3 domains: emotional exhaustion, depersonalization, and personal accomplishment. We use this modified and abbreviated version, which has 3 items per domain. The MBI was actually intended to be scored continuously, and Brock, one of our residents, did some work around this, validating its use as a continuous score. So as you can see, as the score increases, so do thoughts of leaving the program and thoughts of suicide. But there's not really an obvious place to cut off for burned out versus not burned out. That said, most people wanted dichotomies. Are my residents burned out or not? So we looked at all the different definitions that exist, not all of the different definitions, some of the common ones. So you can see that the rates vary. Prevalence rates for burnout vary quite a bit depending on which definition you use. So if you require that a resident has both emotional exhaustion and depersonalization every day, then your rate is only 3%. But if you say they only need one or the other a few times a year, the rate's 91%. We settled on one or the other a few times per week, which has some precedence. You see the citation in JAMA there. So even using that definition, program level rates of burnout vary pretty widely. But the real question is, what is driving it? So this is a very long quote, but is it a problem of the individual or the environment was the first question. So this is a quote from an APD of a program. And next to it, you see a tweet from probably a troll, which captures a sentiment we hear a lot. The secret to wellness is picking the right people and setting their expectations. Before the 80-hour work week, people went into it accepting that from the ages of 25 to 33, they're going to live in the hospital. And so you'd get people who were pretty dedicated to surgery. But is that really true? A recent survey of retired surgeons showed that their most common regrets related to not enough time with family or personal wellness. So is it a problem of lack of grit? A recent survey of over 5,000 physicians show that for physicians as a population are pretty resilient. They have significantly higher resilience scores than the general employed US population, even after adjusting for age, gender, relationship status, hours worked per week, and burnout. And although resilience is related to burnout, even among those with the top resilience scores, almost 30% of them are burned out. We administered a short grit scale in 2018 with our ABSITE survey, and we too found that there was a relationship between grit and burnout, as well as thoughts of attrition and suicidality. However, as with the prior work I just showed you, we found that surgical residents scored more highly than age-matched peers. So our population has already been selected for grit, and it's unclear further selection based on score restriction would be meaningful. Grit also isn't validated as a screening instrument. And we don't know really what it would mean on the other end, right? Like maybe the people you screen out are the people you'd want to keep, because how does grit relate to things that matter for patient care? And even if you use it for identifying people who may need more support in your program, you risk labeling residents and making them vulnerable to discrimination. If you used it as a means for self-reflection, you also risk changing self-perception, right? And and behaviors, and therefore it's a type of stereo threat potentially. So we caution a lot against use of grit as a concept for thinking about wellness. A corollary to this idea that today's residents aren't tough enough is that we're now attracting a more diverse group of people. And those are the ones who are not tough enough. So who do people mean by diverse? There have been many studies demonstrating a higher rate of burnout in women. And one of the unfortunate implications that maybe isn't said but in papers, but is often said on Twitter, is that women just can't hack it. Our data from the ABSITE survey did replicate gender differences in burnout, but the story wasn't quite as black and white as men are tough and women get burned out. Here, each row represents a separate regression model with gender as an independent variable and controls for first trial study arm, PGY level, percent IMG in the program size, and geographic location. And we see that women are more likely to have emotional exhaustion, but less likely to have depersonalization. Brock's work showed us that female surgical residents actually had higher grit scores than men. There was a qualitative study done after this data, in which residents, faculty, and program directors were interviewed about gender differences in burnout. And they cited multiple potential reasons. The first was lack of mentorship. Surgery is a men's club. And there is some evidence about this in the literature. So there are disproportionately fewer women at every phase in the academic ladder. There are issues with recruitment, retention, and promotion. Our interviewees also cited dual role responsibilities for women as a reason for higher burnout. So women are more likely to have primary responsibility for family roles and duties. And this also has some precedence in the data. So in a study of female academic physicians, they were more likely to be partnered with someone else who works part-time and spends almost 9 hours more per week on domestic activities. In a study specifically about female surgeons, women were much more likely to be primarily responsible for meals and housekeeping, and this responsibility was associated with lower career satisfaction. And it's not just about the housework per se, it's about expectations and the role that women are expected to play at home. So in this first study of medical interns, both men and women had similar pre-residency work conflict and depression. And then over the course of internship, they developed more work-family conflict and depressive symptoms, although ostensibly they had the same work. And 36% of the gender disparity in their depressive symptoms was due to that work-family conflict. US Census data shows us that women physicians are more likely to get divorced than men, and the greater work hours were associated with increased divorce prevalence for women only. Oh, that's funny looking. Okay, so another reason that women cited in our study where that women have different pressures and challenges. So these quotes illustrate that. Women have to be better than men to be considered equal. The female residents have a harder time being respected and even liked by many of the people in the hospital. And there are attendings who don't want to operate with female residents and who don't trust female residents to run their service. So I might bucket this all under discrimination. Moreover, there was a lack of empathy. So men reported an inability to empathize with women because they're not women, which may be another source of burnout, that invalidation of that experience. So there have been some studies that addressed pieces of this issue. So there was a survey of 347 surgeons who were pregnant during residency, and 73% had heard either faculty or other residents make negative comments about childbearing. 73% were concerned about being perceived poorly. 64% were concerned that their work had adversely affected the health of their children. 60% perceived negative stigma about pregnancy. And they weren't imagining these things. There was another survey of program directors in which 15% admitted to advising their residents against having children during training, and 61% reported that becoming a mother negatively affects trainees' work, versus only 34% that becoming a father negatively affects their work. Discrimination isn't even just about women's role outside of work and residency. There's a study looking at operative autonomy, and it showed that women receive less operative autonomy, whether it's rated by the trainee or the faculty member. And then there's another study showing that female residents are less likely to win various awards in residency. And that's even true, or even more true, when residents pick the award winners, just suggesting how pervasive bias is. So we, in 2018, started asking about various mistreatment measures. So we asked people if they had experienced gender discrimination, sexual harassment, racial discrimination, and verbal abuse. And you can see the numbers there. They are much higher for women, such that almost 50% of all residents experience some kind of mistreatment, and 71% of all women. And as expected, perhaps, women had higher rates of burnout and suicidality after adjusting for other resident and program characteristics. However, once we adjusted for the fact that women were more likely to be mistreated, those gender differences went away, leading us to think that it's really the treatment of women that drives these poor wellness outcomes. There was considerable program level variation, and also there was not much correlation between different kinds of mistreatment behaviors, just indicating that they are really different problems with different drivers, and it's very context specific. In 2019, we started to do a deep dive into mistreatment. So we asked about specific mistreatment behaviors that you'll see in the middle column, rather than asking globally about whether you've experienced a particular type of discrimination. So once we did that, the rates increased further. So this work by Carrie Schlick shows that 80% of women report gender discrimination with these definitions, and 42.5% harassment. We then looked at factors that were associated with discrimination or harassment, and you can see them on the right. Interestingly, low ABSITE score is predictive for men, but high ABSITE score for women. And gender composition of the faculty is also important. LGBTQ residents were more likely to be sexually harassed, discriminated against, and bullied, with the primary source of all these behaviors being the faculty. But they were not more dissatisfied with being surgeons. They were, however, more likely to consider leaving the program and consider suicide. Tarek did this study about racial discrimination. So 41% of non-white, non-Hispanic, or non-white or Hispanic residents are subject to racial or ethnic discrimination. And you see the rates for the specific demographics down here. This discrimination increases burnout, thoughts of attrition, and suicidality. And finally, we analyzed bullying using the short negative acts questionnaire, which is a validated instrument. And almost half of all residents experience occasional bullying. These residents tend to be women, minorities, and have other vulnerabilities, including being divorced or widowed, being a poor test performer, and they also have poor wellness outcomes. So now we've pretty thoroughly looked at mistreatment, but wellness isn't just the absence of mistreatment. So what else is it about the system? And you'll see from this quote, look at what makes our life hard when we're working, or look at the bigger system with respect to the learning environment. So based on this, we started the second trial. Second stands for Surgical Education Culture Optimization through Targeted Interventions Based on National Comparative Data, another mouthful. One of the first things we did was to develop a conceptual model of resident well-being. A multidisciplinary work group reviewed existing models, including the areas of work-life model, the coping reserve model, the Stanford Well MD model, the Shanafelt model for physician burnout engagement, and the National Academy of Medicine Task Force Systems model, clinician burnout and professional well-being. And our final model is shown here. We highlight several domains of the learning environment that impact surgical resident well-being and burnout. And I've already discussed mistreatment extensively, but others include, and you'll see the sort of ideas pop up below: efficiency and resources, faculty engagement, meaning in work, resident camaraderie, program culture and values, work-life integration, and workload and job demands. And each of these domains interact with individual mediating factors, such as grit or resilience, to influence where residents fall on the well-being burnout spectrum. And then this, in turn, has implications for patients, other clinicians, healthcare organizations, and society as a whole. We queried each of these domains on the 2019 and 2020 ABSITE surveys and did a confirmatory factor analysis, which demonstrated adequate fit. And we did a logistic regression as well, which demonstrated that all the domains were independently associated with burnout. We've just started to analyze the data on the other domains, but really the purpose of this data is to provide benchmarking for programs so they really know where they stand. So every year after the ABSITE, we aggregate the data for each program, quartile it, and tell them how they're doing relative to everyone else. So you can see, for example, here, this first box is burnout, and this program does in the third quartile for overall burnout and emotional exhaustion and depersonalization, but is in the fourth quartile, or the worst quartile in the country, for personal accomplishment. And this is for comparing them to all programs in the country, comparing to other programs of their size and other programs of their type, meaning academic or university-based programs. And once they get that report, they then have access to a toolkit of interventions to help them address those specific issues that they've identified. To populate our toolkit, we identified programs in 4 ways. We did snowball sampling of programs famous for wellness. We looked at their data and found programs that score really well, like this all green report, and programs that score really poorly, like this all red report. We surveyed program directors about innovative things that they were doing, and we did a literature review to identify best practices, guidelines, and review whatever evidence base exists. We then visited 15 programs around the country. Our team includes surgeons, residents, psychologists, psychiatrists, sociologists, and qualitative researchers. And on each program tour, we did resident faculty leadership and support staff interviews and focus groups, observed conferences, and hosted a happy hour. So this gave us a ton of really fascinating and useful qualitative data, some of which you've seen so far. And also it helped us figure out what interventions people have in place in their programs. We then wrote up a how-to on each one and put that in our toolkit. I should note that not every intervention was obvious to the programs that do them. Sometimes it's a cultural practice and they don't think there's anything special about what they do. That's why it was really important for us to get on the ground there. That said, after we came back from our 15th interview, everything shut down and moved to work from home. So we couldn't travel anymore, but it became clear that current events were highly relevant to resident wellness. So we started to conduct virtual focus groups with programs around the country to figure out what they were doing. First around COVID, after which we built 3 interventions. And then second around racism after George Floyd was killed. And we're currently working on 12 interventions for that, as well as a national mentorship network and an anti-racism speaker series. Currently, our toolkit has 50 plus interventions, and they're organized like our conceptual model and our wellness report. The idea is that programs see where they need help on the report and go to the corresponding section in the toolkit, and then they can further filter by how much the intervention costs, how much work it is, how much time it takes, how culturally feasible it is, and we have a self-assessment for that, and other such factors. So here is an example intervention. This is our intervention on holistic application review, which each intervention has a step-by-step how-to instructions that you can see here. And it also has downloadable and linked resources. Like this one has a gender bias calculator for recommendation letters. It has the AAMC best practices for conducting residency program interviews, the AAMC diversity engagement survey, a link to the APDS diversity and inclusion toolkit, and it has, I think what most programs find interesting is the scoring form that Penn uses, which has been doing holistic application review for a while now. And the coach for this intervention is Carrie Ahrens, the PD at Penn. And so we try to make each intervention as out of the box as possible so that not every program is reinventing the wheel as they start to address their issues. We provide some implementation support around various interventions in the toolkit. So far we've done 13 interventions in which 62 different institutions have participated and 174 people have signed on. We also send out newsletters as we are constantly updating the toolkit, and we do one-on-one office hours with program directors to go over the report and sort of point them in the right direction in terms of the toolkit. All right, so the overall second trial is designed as a pragmatic cluster randomized controlled trial, just like the first trial. So programs enroll as a whole, and we don't mandate or prohibit anything. Intervention arms programs get all the resources we just discussed, the report, the toolkit, and implementation support. But control programs, we really discussed a lot what they should get when we were developing the trial. So we convened a bioethics panel led by Peter Angelos at University of Chicago, and they outlined these challenges to think about. So first, equipoise, second, confidentiality, and third, maintaining strong training. So is it unethical to have a control arm? Obviously, everybody wants everything. And this is something we heard a lot from PDs when we first started thinking about this trial. But that said, not everything, most things in our report are experimental. Other than the MBI and the suicide question, nothing's been validated yet. Also, interventions take up time, energy, attention, and money. And if they're unproven, there's real potential harm by focusing everyone's effort on them. So with the help of the ethics panel, we decided to give control programs a limited report that you'll see here. It includes their performance on the MBI, suicide, and thoughts of attrition. We also give them access to all suicide interventions. And again, because it's a pragmatic trial, they aren't restricted from working on wellness. They just don't get further help from us. Therefore, they likely represent the secular trend in wellness and surgical education. We figure out on the back end what everybody worked on by conducting a survey of program directors every year. The second issue identified by the ethics panel was confidentiality. So many of the items on our report are of a sensitive nature, and we wanted to avoid retaliation against residents at all costs. So first, the data come to us from the ABS de-identified. We're not able to unmask the data and trace the responses to a particular person because we never have those identifiers. Second, because we don't want programs to try to back calculate how many residents report any particular metric and then try to guess who they are. We only report data in quartiles like you see here. We don't tell them, we also press any items in which the denominator is really low. So if there are less than 4 racial or ethnic minorities in a program, we don't give them the program about racial or ethnic discrimination. And then finally, we don't give any programs that we tour any feedback on what we hear while we're there, unless it involves harassment and suicide, and we do disclose that to people before we talk to them. Programs are very concerned about confidentiality as well. So both because they're worried about the implications if the accrediting body were to find out, and also because they're worried about struggling with recruitment if medical students were to find out. So to address that, our contract with the ACGME explicitly states that they have no access to data. They only see it aggregated in the same format as everybody who reads our manuscripts do. And then Programs enrollment contracts also explicitly state that they can't advertise their data. And this is really patterned against or after what happens in the QI world. So we don't want people to infer results based on advertising in other places. So just nobody can advertise. Finally, we encourage programs to share their data with residents, but we don't mandate it. So each place decides whether or not they want to release it to their own residents, faculty, or administration. Currently, there are 215 surgical 215 surgical residency programs that enrolled. I think it's currently down to 212 because one closed and a couple merged. The primary outcome, obviously, is resident well-being. And again, we're measuring that in terms of the MBI. We also continue to ask our questions about job satisfaction, attrition, and suicidal thoughts. So what's the downside of the trial? So these quotes really highlight that. So first, if you don't put them under any stress to be good, then people don't read for cases. People don't know what they're doing in the operating room. We just want them to be feeling well all the time, and people squeak through without knowing very much. Or I think you can create a program where everybody's very happy and would probably score very high in the wellness scale, but the training's not very good. So clearly people are really worried about whether this could affect education. So educational outcomes are the second thing we're looking at. So we will assess ABSITE performance. We'll assess program level board passage rates, the ACGME case log to determine whether or not the operative experience changes, as well as case-by-case autonomy data to figure out whether the daily experience of operating changes. We'll also, like the first trial, assess patient outcomes using NSQIP and Medicare data. So the overall goal, and what I hope we prove, is that wellness is necessary as performance enhancement. And I hope that reframing happens globally. So this chair, I think, really encapsulates that. She says, people ask me all the time, well, you do wellness with the residents and then they don't want to do anything. They're lazy. That's actually not what I experienced. If people who are happy, who like being here, they actually work harder. I feel like they'd do anything that I ask, even at the expense of themselves, because they feel that way. And so we'll see in 2022. So this is our team at SoQuick. That this is obviously a huge multidisciplinary effort, although I'm the one speaking here. All right, I think we're done a bit early, so I'd love to hear feedback or questions, if anybody has any.
I'm opening up the chart here, the chat, to see what we have. As people are thinking about questions, Dr. Hu, that was great. That was really, it was a very interesting discussion. And I think one that all of us in medical education, whether it's on the GME or the UME level, are struggling with all the time, is this balance of wellness. And I think what that last chair comment that you put up there encapsulates so well of this notion that, might happier residents have better outcomes and do well because they're excited to be there. So I thought it was it was intriguing, it was insightful, and I think it's going to lay the groundwork on how we can all become better educators as we navigate these challenging times ahead.
I hope so. I mean, I believe that to be true, and I don't know if other fields are as resistant to that thought as we are, but I would be curious to know that. There are some other fields picking up second trials. So emergency medicine actually just did their survey.
So Dr. Trainer put a question up in the chat, which was, based on your site visits, are there any pearls that you've picked up on that you think could be transferable to other fields as well?
So pearls about specific interventions, everything from our toolkit is built from other sites actually. So there's a ton of stuff. And I think it just depends specifically on what your issues is at your program, like it is so context specific. Or do you mean in general about sort of generalities about understanding wellness, I guess?
Maybe, I don't know, Dr. Trainer, if you wanted to, if you're able to just ask the question outright, that might work too.
Sure, I'll unmute and ask the question. So I think a lot about our pediatric trainees, both at the residency level and the fellowship level. I'm also at Lurie, and am wondering what sorts of things you figured out by going, and because you said there are things that places do that they don't consider extraordinary, but when you saw them, you realized they were extraordinary in comparison, or they stood out for you. And you've placed theoretically all of these into these toolkits, which you share with surgical training programs. So me, working with pediatric training programs, what insight can I learn from those? Are the toolkits available generally? So that we could take a look at them and see what might be applicable in our situations.
So you could look at them because we allow programs to share within their own institution, and Northwestern happens to be an intervention site. It would have been very awkward if we had not been, but so I could share it with you if you're interested in seeing specific interventions. I think, here, let me go back to the slide about the different things that matter. I think one of the resistances to wellness in surgery is it sounds so fluffy. Like everyone thinks it's all about yoga and time off, and it's bigger than that, right? It's about how the whole program runs. Hang on, I'm just trying to figure out how to get back to, I guess I have to go through one by one. It's really about all of these other things, which aren't typically thought of as wellness. So I can go through some principles. One example that we always give, we went to one place where they had tried to put in a wellness intervention that went really poorly, and everyone became demoralized on both sides because it didn't go well. So they had thought, we'll put yoga in, and we will find somebody to do it for free for the residents, and we'll schedule it, and everyone will just be able to do it. But they scheduled it at, I think, 7 or 8 p.m. at night. And so residents felt like, first of all, we didn't say we wanted yoga. And second of all, now we have guilt about not going to yoga. It just becomes like another checkbox. Like, now do we need a yoga champion to make us go to yoga? And the faculty felt like, you guys aren't helping yourself. Why don't you go to this yoga we provided? So I think having voice is really important for residents. There's already like a huge loss of control when you enter residency. Like, you don't have control of your schedule, your workload, whatever. And so just having that one say, like, this is important to me, is really important. And second, I think another thing to learn from that is that wellness is different for everybody. You have to have a menu of options. That yoga may have been really meaningful for like a couple of people, but for everyone else, they wanted just the time. Or who knows, they would rather stay late and operate, but actually get to do something. So I think you have to talk to your residents to figure out what it is that's going to resonate with them. So even people with access to the toolkit, we tell them, and with the data, we tell them, discuss the data with your residents, try to get more granular information about what's going on, and like look through the toolkit with them and figure out what they need. I don't know if that answers your question.
No, it does. And I definitely will be reaching out. You seem to be able to share the toolkit.
You know, I think I might have, did I have bonus slides at the end about tips? I might have just gone through all of them. Yeah, the first one was believe the data. I feel like there's a lot of Kubler-Ross, like we stay in shock and denial a long time, especially for surgical programs. Hang on, what else? I told you this. Told you this. Oh yeah, one other thing. Don't assume it will be painful for you. I think a lot of people think that the work is going to go uphill, but first of all, it's not just about the work, right? It's not just time off. And I think everyone can be well. Like there's been some data that Elaine, I think she's on here, she's the psychologist who works with second trials, showing that emotions are contagious. And so happy residents may lead to happier attendings, not necessarily more work. And then the other thing is it may be easier than you think. So, so like this resident said, it's not like we're doing it every week, it's just once a month, and it's a small thing, but it's dramatically shifted the way that we relate to each other. And then this chair said that she did it with pretty minimal cost. What residents need to think is that people are investing in their well-being, which doesn't cost anything. What else? I said that options. Yeah, that's it.
Any other questions, comments? And, again, feel free to put it in the chat box if other people have reactions to it. It doesn't necessarily even have to be a question, just part of the conversation. And so it sounds like this study is going to be ongoing for the next couple of years, right? Gathering all the data. If I remember looking at that one figure that went till 2022.
Yep.
So are there interim points that you're anticipating seeing data or ideas and then adapting moving forward? What might happen in the meantime?
So we do the data collection every year at the app site, and we do a little bit of like analysis into which questions aren't worthwhile. So for example, one thing that I thought would be really important last year was the coordinator, like the residency coordinator helps me do my job and is supportive. But there wasn't a lot of spread on that. I guess most coordinators are pretty helpful. So we do that analysis to know that the question isn't useful and to cut it. In terms of like the actual primary outcome, the wellness outcomes, we are going to do an interim analysis with this next app site, and then we'll have a data safety monitoring board just to make sure we're not doing anything crazy and things aren't falling off the rails.
I'm also curious about what the overall cost of this is across, like, I think I see where your funding came from, and obviously the first trial gave you the infrastructure and the credibility to pull this off. But if another discipline is pondering it, what might that entail?
So yeah, these are our funders down here. So the ACGME and the ACS are pretty much the two that are funding the project. A lot of and that pays for things like the travel, the staff, but the residents actually come in for us through SoQuick, and so they're not on those particular expense lines. The ABS gives us the survey every year for free, and then the other organizations are just providing like a mouthpiece. So other specialties have come and wanted to do stuff in their own specialty, and it sort of depends on what their setup is, but most of them go to their own board and their own program director society and ask for either funding or like in-kind support, basically. And I think everybody that we've worked with has figured out something, just because every specialty now recognizes it's a hot topic, an important topic, under address topic. So we're currently working with emergency medicine, like totally blanking, vascular surgery. We've had people reach out from OBGYN, and I think they're probably going to start doing work. I actually didn't see who was talking, so I don't know who asked that question.
It was pediatrics again.
So yeah, like the AAP maybe, or there's got to be an APDS equivalent for pediatrics.
It's the ABP, the American Board of Pediatrics. We don't have as much money as the surgeons, though.
Well, I mean, it's not that it's coming to me. Like I'm like 5% effort or something hilarious. So I think that if you could get them to loan you, do you guys have an annual exam?
We do, yeah. In training exam.
Yeah, so if you have an in-training exam and you could tack your survey onto that would be a start for some preliminary data to prove that you need to do it. And you can have our survey. That's free, basically. I don't know if you have someone to do the stats for you. I imagine you do, since you do education research.
From one Jennifer to another. Jennifer, Ryan, could you share your comment or question up there that you put in the chat also? You're just muted right now. There you go.
I was just kind of capturing that some of your findings were consistent with a lot of personal interactions. It's about the person. It's about finding what's meaningful to that individual and doing something thoughtful to enhance their wellness versus expensive. So the expense would be in the really good analysis of your program and the needs assessment. Is that was it a needs assessment? How do you capture what's meaningful to them? Like, how do you build, is that the survey, or is there more to it in that respect?
So the survey basically has, it queries about each of those domains. And the idea is that the report gives them a like broad strokes. Like your issue is, hang on, let me try to find a report. So your issue is faculty engagement for this program, for example. So your residents answered poorly about a mentor who genuinely cares about them and their career and appreciation of their work. So it just gives them an idea of like where to start, but they still have to talk to their program about like what would make you feel appreciated. And they can look in the toolkit and get some ideas about like things other programs do for appreciation. So for example, one program did like an intern breakfast that's annual, in which they like collate quotes from every attending about like, this is the thing I love about you. And they buy them food and like it's a morning off or something like that. Or another program, and we stole this at Northwestern, does birthday cards, which is such a small thing, right? Like a $5 Starbucks card and like a little like happy birthday, but it makes people feel like you care about them. And so yeah, I think it depends. And you have to talk to people to figure out what it is. Did I answer your question?
I think it's a project, not just a question. So thank you. You gave a good vaulting point.
All right, Dr. Hu, any other final concluding thoughts, unless anyone else has any other questions?
I'd be curious to hear other people doing other specialties. It's a question for everyone else.
Hi, it's Newport with plastics. So we actually just finished our national ASPS meeting, and it was all virtual. And the last day of the half day of the conference this weekend was actually focused on not just resident wellness, but also like resident and faculty wellness. And I think when they sort of presented all of the papers from plastic surgery, what we all kind of figured out is we actually don't even know the scope of the concerns and the problems, because to be honest, people are not really measuring it. And so I think that's for us like a big starting place, is that we realize that it's important and we need to deal with it, but we just don't even know what to address first. So it actually created a couple of like work groups for what are going to be important things for the society in the next couple of years. I would say from like a resident level, we definitely try to use all of the wellness resources that Northwestern has, but it is a little bit challenging when our residency size is pretty small. So there's only 14 residents in the entire program. It's also then kind of hard to figure out what resources we should be allocating for, resident wellness and kind of improvement in like their mental health and how they're doing, especially when you don't have as many dollar resources.
We have really good institutional resources, I feel like, compared to some of the other institutions we've seen. Like we have Ashley Bassett, who is about to go on maternity leave. But I think it's huge to have like that person with a face, so that it doesn't seem so scary to access resources, because you've already met this person. I don't know if you guys have used her, but she does, the way we started introducing her to our residents was she does this wellness roundtable in which they talk about like difficult cases and coping. And she alternates them, like she does one with just her and the residents, and then she alternates them with ones where she brings in a faculty member and they talk about specific cases. But it just is like one more touch point, so like if somebody needs something, it's a little bit, it lowers that barrier to entry a little bit, because that person's familiar and it doesn't feel like I have a mental illness, like it addresses that stigma piece a little bit. Nancy put in some
Yeah, Nancy, thanks for sharing that. I don't know how much, I mean, you mentioned you had one slide where you went from in-person to COVID and the Zoom and everything. And I know from my perspective as an APD in emergency medicine, that COVID is having a significant impact on all of our, what we would say, normal wellness activities, right? The gatherings of residents, class nights out, coming over to a faculty member's house, and all these things that COVID has just thrown a wrench into all of that. And I wonder if you've seen that or heard that in your discussions with other surgical programs, or if anyone else who's here today has had any similar experiences. And we were coming up with creative ideas when the weather was nice, but now, like the rest of the world, as the weather starts to not be awesome anymore, I worry that a lot of that will be significantly impacted as well.
Yeah, I definitely worry about that. One of the 3 interventions we built out about COVID was about how to create those touch points with residents. So we did this when the world first went on work from home. So this was back in March. So there was an intervention around like virtual happy hours or additional didactics so that you would still get that FaceTime with residents who are bullpenning at home. I know from the Northwestern perspective, we were trying to figure out how to do a socially distanced retreat, and our residents actually came up with this idea, which was great. They did they did boating like on the river, in which like each boat is a single person, but the boats are more than 6 feet apart.
Yeah.
That was a really smart way to get around that. I do worry about what's going to happen in the wintertime because, the safest thing was outdoors. And so, I'm also curious what you guys are doing. Back when we did the intervention, a lot of the Zoom check-ins, it was like kind of this fun, like I can see a lot of people like the Brady Bunch, and it was like novel, but now everyone has Zoom fatigue and I'm not sure that's going to work as nicely anymore. So I'm curious what other people are doing too. I will say, talking to other program directors, particularly in New York during the peak of this, it seemed like most of the anxiety was around the idea that the program was trying to protect you. So all of them talked about PPE, but they said that it was more about like whether they felt like it was being withheld than whether or not they really had it. So, for example, the program director at SUNY Downstate went and bought like raincoats or ponchos or something for everybody because they had run out of gowns. Or she bought glasses for everybody because they had no eye protection. And so like trying to make up for that gap and like, even though it's not ideal, I think help people feel more cared for. We'll see on the other end when the data comes out.
You're looking for ideas. Someone just messaged me. They were going to do a virtual Zoom cooking class for their residents as another way to keep people engaged. As part of their wellness committee.
I like it.
Well, I guess we're just about out of time here. Dr. Hu, this was a really engaging discussion and a really important idea that's on all of our minds right now. So thank you so much for taking your time to share with us this evening. And on behalf of all the Feinberg Academy of Medical Educators, we'd like to thank you for joining us. As a reminder, please make sure if you'd like to get CME credit that you fill out the survey. Andrea has just put that into the chat as well, so that you can get that. And if you'd like to continue learning this evening at 5:15, so in 20 minutes from now, there will be a post-time session. I'll be leading the session actually this week. Faculty development workshop, which is all about integrating active learning strategies into your Zoom sessions for anything you'd like to do using Zoom, which we are all spending so much time on these days. And so if you're interested, I'll see you there. Otherwise, a huge thanks to Dr. Hu for this past session, and have a great evening. Thanks so much.
Thank you.
Thank you.
Thanks so much for being here today. I don't know if there's anything else formal at the end of this that I'm supposed to do. I wasn't given those instructions.
Me neither. So I thought I would hang out and see.
Yeah, this was great though. I think it was timely and important. It was a great discussion.
Thanks. If you have any feedback for me, I'd love it because I have to give a grand rounds in like a couple weeks about the
Oh,
same.
really?
Yeah. I noticed I ended very early. I was like, apparently I talked too fast.
Yeah, I think we have access to the CME survey, so we can compile that and send it to you.
Awesome. Thanks.
Yeah, I mean, I think the best part at the end is the discussion. I mean, it depends on your group, right? If you're looking for feedback, one thing that might be interesting. Are you doing this over Zoom, I presume, or in person? Yep. Yeah, I mean, it could be a fun, interesting endeavor to break people up into a group, like small breakout groups at the beginning, or even ask them, like, what do you guys think contributes to mistreatment, especially in that section? Like, what are the factors, and see how close they might be to hitting the nail on the head.
Interesting.
Because there's always that really interesting thing where